Here's an outline of my presentation. Okay, first we need to know about the anatomy and physiology of the retina. We know that if you see retina, I think most of the doctors, after they purchase your machine, mostly they will ask you first, and then before they ask the retina consultant. So at least you have to know a basic or one thing about the anatomy and physiology of the retina. So if you see the retina is an organ behind the eye, and then you can see the macula over here. This is the central part of the retina and the optic nerve head. So the center of the macula itself, the diameter is 1.5 millimeter for high spatial acuity and color vision. So you know when patient got a disease that is involving the macula, patient usually not only suffering from reduced visual acuity but also color vision. Inside the macula itself, the fovea, there's this foveal vascular zone ranging around 250 to 600 micrometer, where you cannot find any vascular there, where you can see it on the OCT angiography. Okay, this is the more detailed scheme of the macula itself. You have the areas centralis, perifoveal zone, and then this is the fovea. And then the central part here, we call it umbo. It's just okay. So when light striking your eye, the light will come into the pupil, and then the lens will deflect it into the retina. And then after the light touching the retina, the light must travel the full thickness of the retina to reach the RPE first, and then the photoreceptors. And then after that, the photoreceptors generating an impulse that will travel from the cells in the retina, and then through the ganglion cells, and then through the optic nerve, and then to the eye, and then we can see. So the neural retina itself is embryologically derived from the inner layer of the optic disc. It consists of the three main groups: photoreceptors, bipolar cells, and ganglion cells. So photoreceptors is over here, ganglion cells is somewhere over here. The bipolar cells is somewhere over here, and then the ganglion cells is over here. We have also horizontal cells, amacrine cells, and other supporting cells, mainly the glial cells for the architecture of the retina. So this is the simplified visual cycle, or how we see. So from the receptors, there's a synapse of the cells there. The impulses travel through the bipolar cells and then ganglion cells, summon the responses from bipolar and amacrine, and then develop action potentials, and conducted to the dorsal lateral nucleus in the brain, and then we can see. Okay, these are the photoreceptors. You can see here, this is the rod. Why we call it rod? Because the shape itself looks like rod, and then this is a cone because the shape is triangular over here. And then the rod is responsible for vision in dim light and produce images consisting of varying shades, black and white. But when you want to see colors, it's the cone job to see colors. So cones adapted to bright light, fine details, and color vision. There are approximately 110 to 125 million rods, while cones is actually only 6.3 until 6.8 million cells, where the rods are absent in the fovea. That's why in the fovea, they are responsible for color vision, because most of the cells in the fovea are cones. The rods are most densely in the peripheral retina. So as we all know, if we only see the retina through the funduscopy or a fundus photo, we can see the pathology, but we cannot really see what's happening inside, behind the retina or under the retina. So that's why we need optical coherence tomography. Back then, before the invention of optical coherence tomography in maybe around 1991 by David Wang from MIT, We mainly depend on the clinical findings or maybe the angiography to know what happens inside the retina. But now we have optical coherence tomography, which is a non-contact, non-invasive imaging technology used to obtain high-resolution cross-sectional images of a tissue, which is a retina or anterior segment. So the term of optical biopsy, I'm sure that you are familiar with it. It's the optical coherence tomography. So I think I won't go too deep into this, but basically, I think you know it well, better than me. So I won't go through this through the detail, but basically OCT works based on a light scattered, that is traveled inside the eye and then back scattered from the tissue that the light hits, and then it goes through the monitor inside the machine, and then we get the image that we can see in the OCT. Okay, so the OCT can tell morphological changes in the retinal interface, retina, until up to the choroid. Well, we now have a source OCT where the wavelength is quite far, the penetration is very good until we can see the sclera of the eye. So we can see what occurs in this tissue and where those changes are located, whether it's an inner retina, outer retina, RPE. We can see from the OCT and how abnormal they are. The OCT analysis offers qualitative and quantitative measures. Qualitative, you can see the morphology, whether it's a normal or anomalous structure, and where's the location. The reflectivity, we can see there's a hyperreflective, and shadowing or increased transmission. And the quantitative analysis, you can see numbers. So thickness, volumes, or areas of the abnormality in the retina. Here's the anatomical layers and their reflectivity based on OCT. So we have a hypo and hyper reflectivity based on the light that's scattered back from the tissue. So hyperreflective bands is mostly posterior cortical vitreous, IPL, OPL, ALM. We have the hyperreflective zones, hyperreflective bands, hyperreflective zones again, you can see here. So I usually tell my patients that the retina is like an antenna. No, it's like a sensor where it sends the impulse, and then this is the electrical cables. So the cable is over here. If you can see, the cables run smoothly, so the retina is okay. But when you see that the cable is like scrambling down here, you know that you have a problem there. So from up here, this is the ILM. This is a footplate of the molar cells. And then we can see the nerve fiber layer, ganglion cell layer, inner plexiform layer, inner nuclear layer. The nuclear layer is actually more hyperreflective over here. And then the outer retina, then we can see there's this lines over here that is actually important in measuring or subjectively seeing the function of the retina. So you can see maybe for patients after retinal detachment, the retina is off and the retina is reattached. If you cannot see these lines over here, so you can say that the prognosis of the visual acuity is not very good. So if we see an OCT image, the viewing process is from the vitreous cavity through the RPE. So if maybe if you have a training or some doctors ask you about how to read an OCT, right? You can say that whether the vitreous is normal, whether the inner retina have any problems, and then you go to outer retina and locate the RPE. Is the RPE is smoothly going like this, or there's a bump, or there's a discontinuation on the RPE, or discontinuation on the every part of the lines over here. And then you can see the below the RPE, the choroid. Is there anything happening there? Pachychoroid or dilated choroidal vessels. And then after that, you can see the quantitative analysis, which is the thickness map. Okay, so there are actually normal features on OCT. So sometimes I get a consultation, OCT image that is consulted by one of my colleagues, and they ask whether this is like normal retina, or this is like is this an epiretinal membrane or anything, because there's this hyperreflective line, hyperreflective blend over here. This is actually normal because the bright reflective layer thickens nasally. This is the fiber layer. So the knowledge about the normal OCT scans you have to know. And this is also, is this a shadowing? Is this normal, or is this like a intraretinal hyperreflectivity? No, this is actually a blood vessels that is capturing a shadow through the RPE. So we need to remember that OCT, we cannot really interpret it alone as in isolation. We need to always correlate this to the clinical findings, the other examination. Okay. This is the common causes of abnormal reflectivity on the OCT. So if you have a reduced reflectivity, it may be fluid, like this. This is like a dark, hollow areas over here. This could be fluid. Or increased reflectivity, for instance, heart exudates, calcification, hemorrhages, or fibrosis. And here, in this OCT scans, we can see, of course, this is abnormal, right? The foveal depression is still there, but you can see this is a pigment epithelial detachment, and then in the hollow areas here, we call it the subretinal fluid, and we can see here that elongation of photoreceptor, outer segment, and this is, we call it a subretinal hyperreflective material, and this one is probably a fibrosis. So ABCs of macular OCT. The first one, we need to see the vitreous and vitreoretinal interface, whether there's vitreous opacity, epiretinal membrane, or vitreomacular traction, for example, where you can see that the foveal depression is gone, whether it's it becomes like a straight line over here, or maybe it goes up when the VMT is happening. And then the second one is you have to see the inner retina. How is the foveal contour? Whether there is an edema, whether there is any cysts, exudates, fluids, location of the abnormalities, whether it's in epiretinal, intraretinal, or subretinal. And then the outer retina, you have to see the lines, the inner segment, outer segment junction. Now we call it an ellipsoid zone. It's not no IS-OS junction anymore. The interdigitation zone, or how is the external limiting membrane, whether there is a disruption or is a continuous line. And we go down to the RPE, whether there's a PED, drusen, sub-RPE fluid, fibrosis, atrophy, or shadowing. And then the last one is the choroid. But the choroid is thick and thin, or whether there's enlargement of choroidal vessels. So there has been this new diagnosis, we call it the pachychoroid spectrum disease, where the main pathology is in the choroid. It's like CSER, central serous choroidenopathy, or pachychoroid neovasculopathy, or anything that is thought that mainly is a choroidal disease. So choroid, do not forget that we need to also examine the choroid. Okay. This is the example for vitreous and vitreoretinal interface. And now the swab source OCT is very good details of the vitreous. You can see here, there's a faint white lines over here. That is actually the vitreous cortex, or the anterior hyaloid. Okay, sorry again. So this is also the vitreous. You can see this is the lamellar, hyperreflective images over here. And otherwise, like a spectral domain OCT vitreous, we cannot really see a vitreous like this. So, and the second one is the vitreous opacities. You can see like a small dots over here, the hyperreflective dots. This is the patient with uveitis with Vitreous cells. And this is an example of patient with vitreous and vitreoretinal interface abnormalities. You can see here there is an epiretinal membrane. And this is a vitreomacular traction. So the vitreous contracts and then make the retina contracted upwards. We have an intraretinal cyst. So the cyst in the retina is mostly in the outer plexiform layer areas because there's no nucleus of cells there. There's just a synapse of the cells. So it's mostly like a loose tissue. So whenever fluid accumulates, it accumulates on the outer plexiform layer. So this is the shadowing. Okay, so that's the vitreous interface. And now we see the inner retina. So inner retina, by definition, is the structures between the ILM and the external limiting membrane, which is the retinal and fiber layer here, ganglion cell layer, inner plexiform, inner nuclear layer, until outer plexiform layer. Okay, so this is I would like to remind that we need to check the segmentation before reviewing the retinal map thickness, because the segmentation over here, if say the segmentation is not correct, so the retinal map thickness will think that the ILM is like, let's say from here to here. Or maybe we want to see the abnormalities in the RPE, but the segmentation is not correct, then we will have not correct results, incorrect results. Okay, this is another example of OCT in patient with diabetic macular edema. We can see here, this is an epiretinal membrane, posterior hyaloid, and there's fluid in the outer plexiform layer. There's shadowing from hard exudates. So sometimes it's maybe a non-retinal specialist or a new retinal specialist sometimes said, is there any discontinuation of the RPE? Is this like a choroidal neovascularization, or is this an AMD patient? Because they see that the RPE is like broken down over here, but it's not. It's actually shadowing from the hard exudates above. So the light cannot pass through, so it casts the shadow on the RPE. And then the hyperreflective dots over here, we call it an intraretinal exudates, which we can find in most of the diabetic macular patients. Feel free to interrupt, or if you want to ask anything while I'm presenting. Okay, this was also an interesting finding that we can see during the COVID pandemic, where we can see that the cross-sectional B scan, there's a hyper-reflective flashes over here. And then we call the term the PAMM. And then I suddenly don't remember what PAMM stands for. It's the posterior acute middle maculopathy. Okay, so it's mostly because of the vascular disease from the COVID. It causes the inner retina becomes ischemic, and then you can see here. It's actually reversible. So this is just to show that OCT is actually can actually find some like biomarkers or new findings from the new disease. So we actually live at a very interesting time where the advancement in ophthalmology is very rapid, very swiftly emerge. So we can see better, and we can understand better the pathophysiology of retinal disease. So vitreoretinal interface, inner retina. Now we come to outer retina. So in the outer retina structures is between the external limiting membrane and the RPE, which consists of outer nuclear layer, external limiting membrane, and the ellipsoid zone. Easy. which was called the ISOS junction, which is actually the ellipsoid zone shows the integrity of the photoreceptors. The first line here is the external limiting membrane. This is the ellipsoid zone. This is the RPE. Okay. This is another example of a retinal disease that we can detect in OCT. Okay. Okay. This is the macular edema that is associated with retinal vein occlusion. You can see here from the fundus photo, there's a ghost vessel over here, the whitish blood vessels, the broken blood vessels because of the retinal vein occlusion. And then maybe from the fundus photo we can only see that there's a reduced foveal reflex, but on OCT we can see from the fundus photo alone, we might wonder whether this is still have an edema or not, but from OCT you can clearly see there's still edema. There's an intraretinal fluid over here, and then after injection of anti-VEGF, the fluid disappeared, but you can see that there's an external limiting membrane and ellipsoid zone disruption, so poor visual prognosis. Okay, outer retina, and then we come to retinal pigment epithelium or RPE. You can see from here, the fundus photo is hazy from cataract. We can see here there's a bump over here, which is actually associated with drusen. I'm not really sure you can see it, with drusen over here. And this is a dry AMD, we call it. And on the bottom image, we can see that this is a wet AMD. You can see like some exudates over here, and then, we cannot really see the blood. But from OCT, we can see the abnormalities is actually happening on the RPE, and then we can see the RPE disruption, subretinal fluid, and subretinal fibrosis. This is what I just told you about. We need to check the choroid. With swept source OCT, now we can see clearer the image of the choroid and even the sclera. This one is over here, it's in sclera. And if we only use the spectral domain OCT, the choroid mode, you can actually see it, but not as clear as the swept source OCT. So the choroid is important in assessing pachychoroid spectrum disease like CSCR, PCV, and pachychoroid pigment epitheliopathy, pachychoroid neovasculopathy, and etc. Okay. That was the qualitative analysis, where, well, you need interpretation of a retina specialist to do a more precise diagnosis, but you get the gist. This one is for the quantitative analysis. You can see the thickness map over here. Sometimes patients wanted to know the numbers. So say patient with AMD, and then after a few injections, she thought that her vision is not very much improved, but we can see from the OCT whether there's an improvement or not. And then sometimes patient wanted to have a quantitative analysis. So let's say, sir, ma'am, your vision probably is not improved as much as you want it to, but as you can see from the quantitative analysis, your central macular thickness was, let's say, 350, and now it's like 275. So there is actually a result of the injection that you did. And you also can see the volume over here. And this is the report for quantitative analysis. This is the areas that you want to see, retinal thickness map, and GCL, and thickness map, and RNFL. Okay, so we move on to the retinal cases. I think I'm just going to move over here so that my neck won't be okay. To balance out. Okay, so this is the common retinal diseases that we usually encounter in our clinic. There is retinopathy, retinal vein occlusion, ARMD, central serous retinopathy, retinal detachment, macular hole, and epiretinal membrane, vitreomacular traction. So first we will discuss about macular edema. So macular edema is actually accumulation of fluid in the outer plexiform layer and the inner nuclear layer as well as swelling of nuclear cells of the retina. So mostly it's on the outer plexiform layer, the fluid. Macular edema is actually caused by the breakdown of inner blood retinal barrier and also the breakdown of the outer retinal barrier. Okay, this is an example of central involving diabetic macular edema, OCT scans. You can see this is the fundus photo. The scans is over there. Anyone can tell me what do you see in the OCT scan? Anyone?
Cystic space.
Okay. You cannot answer that. Okay. Yes, cystic spaces, or we call it an intraretinal fluid or intraretinal cyst. And then we can see also subretinal fluid, exudates, and shadowing from the hard exudates itself. So the retina, the RP itself is actually okay. Okay, this one is non-central involving diabetic macular edema. Anyone? Okay, I think anyone wants to go to the beach as fast as they can. So okay, so this is the intraretinal cyst. It's the small ones. And then, is there anything? Okay, this is the intraretinal hard exudates. But the central part of the macula is still intact, so we call it a non-central involving diabetic macular edema. This one actually no need to do an injection unless patient, unless patient really, you want really bothered by the blurring of vision. I mostly don't do an injection for non-CITME. So this is a post-operative cystoid macular edema. So after cataract surgery, in about 4 to 6 weeks, sometimes some patients develop this edema. So sometimes my anterior colleague gets freak out because post-op day 1 was 2020, and then 4 months after that 2014, and then they abruptly sent patient to me, and apparently patient had this cystoid macular edema. So here you can see that the full field depression is gone. Of course, it went up because there's an edema over there. So we have intraretinal fluid, intraretinal cyst, and then subretinal fluid. I usually give them just a non-steroidal agent with low steroids, and then usually they will be fine after two weeks of treatment. Okay, this one is retinal vein occlusion. You can see from the fundus photo, there's massive flames hemorrhage over here, and then there's exudates coming from the lipoprotein from the leaking blood vessels. And you can see from the OCT scans, the intraretinal fluid again, intraretinal exudates, and then massive subretinal fluid. Usually this kind of patient won't do really well with only 3-6 injections. They need at least 1 injections per month for a year, and probably the visual prognosis won't be good. Okay, there's age-related macular degeneration. Are you familiar with AMD? Yeah, sure. So this scheme over here, diagram over here, show an early AMD, whereas there is a deposit of drusen on the Bruch membrane of the RPE. And then in intermediate AMD, increased number of drusens and also the volumes, the numbers and also the size. And this is a late AMD or a geographic atrophy, where you can find that there's a disruption or a disorganization of the photoreceptor layers in the RPE. So the RPE is gone, photoreceptor is gone. Then you can see the large choroidal vessels behind the retina. And this one, if late AMD or neovascular AMD, can dry AMD become neovascular AMD? They can. So we need to monitor patient with dry AMD over the years. So that's why you need OCT to see whether they will develop neovascular AMD or not. We can see actually from the OCT. So AMD or neovascular AMD happen when there's a disruption on the RPE here, and then the choroidal vessels and the macrophage and then inflammatory response and macrophage response give rise to the neovascularization, choroidal neovascularization, and then the choroidal neovascularization is like a creeping out from here to the retina, and then it break down and give a subretinal hemorrhage. Okay, this is a dry AMD patient. I hope you can see from the back that there is this yellowish spot over here on the macula that is corresponding to the PD, pigment epithelial detachment, that is a drusen. So multiple drusen seen as RPE deformation or thickening that form undulation or irregularities in the RPE. So no fluid, so this is a dry AMD. What happened in wet AMD? You can see here that the choroidal neovascularization has abruptly made a subretinal hemorrhage over here, and then this white tissue over here is probably an old hemorrhage that has loosened its heme, so it's only like a whitish lesion over here. And then we can see on the OCT, the subretinal fluid, there's a serous and hemorrhage. The hemorrhage is actually looked like a hyperreflective subretinal materials, while the serous part could be the hyperreflective, or this one could be because the blood is so thick you cannot really see the RPE. Okay, we can see a small PED over there as well. Okay, this is another patient with AMD. We can see a subretinal fluid, subretinal hemorrhage, and also a PET. This is a patient with geographic atrophy. In AMD, you can see here there's this sharp delineation over here, and then you can see the choroidal vessels. This is the retinal vessels. It's smallish in size, but the choroidal vessels, you can see like a large caliber vessels over here. We can see the choroidal vessels because why? Because the retina is atrophic. You see the thickness of the retina over here is poor, and then we can also analyze here that the ellipsoid zone, the external limiting membrane, even the RPE is gone over here. And then you can see that this hyperreflectivity, the shadowing over here, we call it an increased transmission or reverse shadowing, which show you that the RPE is non-functioning or is not even, is barely there. Okay, see that the ALM over here is, you can still see it, and then it abruptly ceased in the lesion of the geographic atrophy. Okay, this is a patient with PCV. Traditionally, PCV or polypoidal choroidal vasculopathy diagnosed with gold standard, the ICGA, the angiography, indocyanine green angiography. But now we can diagnose ICG based on OCT findings. So that's how OCT is very valuable in our clinical practice and study in the understanding of retinal pathology. So here we can see this actually a polypoidal lesion over here. This is the subretinal hemorrhage, which corresponds to this area. And if you see here in the fundus photo, there's a orangish lesion over here that is presumed a polypoidal lesion that correlates with double hump PED on the OCT. And this is the PED and sub-RPE fluid. Okay, next we move on to the central serous retinopathy, or we call it CSE or CSER. The pathomechanism of action from CSE is actually not really clear, but is thought to be from a few things. It's from the thick rigid sclera or corticosteroid use, or if you have asthma, or you have eczema, you might consume steroids on your daily basis. If you have the risk factor for CSE, be careful. I'm not praying that you will get a CSER, no. It's just that the corticosteroids known to cause a CSER. Or autonomic dysregulation, for example, from stress, or personality type A, maybe you're a perfectionist, or you're a easily stressed person, you're more likely to get a serious retinal detachment compared to your other colleague. Okay, current hyperpermeability and RPE dysfunction and atrophy. Okay, so basically you have a break on the RPE, microrib, and then the fluid from the choroid comes under the retina. If my time is up, please let me know. Okay. Okay, this is another case of a CSER. You can see here there's this bump. It's a bullous retinal detachment, small over here, macula. And from the OCT, we can see a subfoveal subretinal fluid with a smallish PED, a focal area of irregularities or PED. So most patients with CSER have this focal irregularities, and you can check on the other eye also. Usually they have this bump here. Okay, and this is the choroid exam. We can actually measure it. So this patient, the choroid thickness is more than 300 micron. We call it a pachychoroid. Pachychoroid disease spectrum includes CSER as well. As you can see here, dilated choroidal vessels. Maybe after this you can check on your eyes for your OCT and check whether you have a pachychoroid or not. Okay, so this patient has a rhegmatogenous retinal detachment. This is the fundus photo, maybe like what you can see here. That the macula is almost splitting. So this is the area of detachment. Okay, and from the OCT you can actually tell whether this is a macula on or macula off, because the macula on needs like surgery within 24 to 36 hours, where the macula off, it's okay to do it at a later time. So sometimes only seeing the clinical pictures, the fundus photo, the funduscopy imaging, cannot really tell whether this is macula off or macula on, and then the OCT can decide whether this macula on or macula off. This is the example of structural retinal detachment. You cannot see any normal retinal architecture in this picture. Well, maybe you can, with only the RPE here. The retina has been torn apart. This is the fundus photo. We can see the traction over here. Okay. Traction, membranes, and this is the cystoid spaces, subretinal fluid, and then this is the blood vessels over there. This is blood vessels could be from the retina or from the neovascularization. Okay, this is a few, you can see here vitreoretinal interface abnormalities. There's a pseudohole, epiretinal membrane, lamellar macular hole, full thickness macular hole. Okay, epiretinal membrane, you can see there's a line over here. This is a membrane that is a glial proliferation on top of the retina, and it's usually can contract because it has an ability like a myofibril, and it can contract the retina, so it will disrupt the normal anatomical architecture of the retina. Okay, you see here. Yeah, this is the epiretinal membrane. You can see like whitish membrane over here. I usually tell my patients this looks like a glue that is dry up on your skin, and then you contract your skin, and then the surgery will like to peel off that glue. Okay. This is lytic membrane, and then you can see the striae over here. So it disrupts the retina. This is a patient with full thickness macular hole, where you can see discontinuation of the retina over here. And yeah, that is the full thickness macular hole. We can differentiate it from the size, whether small, medium, large, or and you have to measure it between the narrowest part of the hole here. You can measure it from the OCT device. Okay, the essence of all retinal layers, and we can measure the macular hole index, which is if the macular index is more than 0.9, it has a good prognosis of closure. This is a patient with macular hole, lamellar hole. Sometimes you cannot really see on the clinical findings, or you might see whether it's like a full thickness macular hole or not. Then OCT can help you to differentiate. Lamellar hole is a break in the inner retina but intact outer retina, so the outer retina is still there while the inner retina is breaking. No dehiscence of the outer retina tissue. There's vector-macular traction. Okay, it's like a cockroach antenna. Vector-macular traction is it incomplete PVD with persistent vitreous attachments in macula, with a 3 mm radius from the center of the fovea, and anterior posterior traction causing morphologic and functional effect. You can see the traction. It causes a cyst on the inner retina. This is another example of epiretinal membrane due to PDR. Okay, that is the ERM. This is the inner retinal hyperexudates. Okay, this is a cyst. Okay. And the importance of OCT, it can give you a biomarker for a progression of disease, or another better understanding of the pathogenesis. And these are the new landmarks in science and findings in OCT that we recently, the retina community finds. This one is the hyperreflective retinal spots. This is reported in early stages of diabetic retinopathy, vascular occlusion, CSCR, or uveitis. It has been hypothesized that HRS represent aggregates of microglial activated cells, so it's a retinal inflammatory response. So nowadays, the studies for, let's say, predicting the visual prognosis for patients or disease progression for patients mostly use the count of these spots. I don't really understand how they do that, because in here you see a lot of spots here, and how can you measure? I'm not really sure, but they do it anyway. And the other one here, the flying saucer signs. This we can find in chloroquine toxicity. It's because the disease itself, because conservation of the retinal structures and photoreceptor ESOS junction, but the outer retina itself loses the photoreceptors. Okay, this is another one, the outer retinal tubulation. We usually find this in chronic AMD or other chronic process inside the eye. This is a pearl necklace sign that we usually see in chronic diabetes. Okay, so mastering OCT reading is important because it can help us to do an earlier and correct diagnosis. It also serves as a treatment guide to initiate the treatment and to evaluate the treatment that we give to the patients, and also patients' education. This is important because, let's say, if we told patient that you have cataract, they know what is cataract, what doctor is going to do with the cataract, which is surgery. But for retina, sometimes it's hard to grasp the concepts of the retina if we explain it to patients. So OCT, fundus photo, and other imaging is actually help us to educate patient better. That in turns will help us to get patient more comply to the treatment, so they won't lost the follow up and then come back after the disease progressed to a very bad state. And also, I think the trend nowadays, because we have anti-VEGF injections, sometimes doctors just inject without knowing the exact pathology of the disease. So I may find some of my colleagues injecting anti-VEGF to a macular hole patients, which won't do anything. So mastering OCT reading is really important, so we don't give harm to, we don't do any harm to the patients. So if you like to maybe ask doctors, or you meet doctors and then she or he asks you, why do I need to invest in an OCT machine? It's expensive. Not everyone can use it. For example, I will need to go for retinal training and sort of like that. So you tell them that OCT is the ace up your sleeve. It's your weapon in your clinical practice, because OCT, we can do a disease screening and then earlier detection, and we can prevent vision loss in the patients. And also we can do, OCT help us to do a more precise diagnosis and management, treatment, monitoring. So if you don't have OCT, you know, okay, a patient had diabetic macular edema because you see it on the fundus photo, you see it on the clinical findings during the slit line bio. You inject, loading dose 3 times. But how do you know it works? Besides from the visual acuity. But sometimes, not sometimes, more often than not, the visual acuity is not increased at all. But then a patient asks you, so do I need to do another injection, doctor? Do I need to do another jab? I don't want to, because you see, after 3 jabs, nothing happened inside the eye. So the OCT images can give you can show it to your patient, the image of the anatomical changes, anatomical improvement inside the retina that probably not always parallel to the increase of the visual acuity, but the anatomical result itself is good, so you can convince your patient to continue the treatment. We can see the disease progression. For example, patient with geographic atrophy, you can see the progression of the disease, and when the dry AMD patients became wet AMD patients, you can see. So patient won't see you as like a robber. You just want to rob my money for injections, but the injection itself don't do anything to me. So you can see it. You can show the OCT findings to the patient. With OCT, we can have a better medical and surgical outcome. So more often than not, my anterior colleague refer patient to me. After cataract surgery, the vision is not improving at all. So when I see the retina has macular hole, AMD, or any sort of disease, diabetic maculopathy. So if you have an OCT, before surgery, you can actually just take OCT scans to all your cataract surgery patients. And when you see the OCT scans, even if you don't really know what's happening in the retina, you can tell the patients, I'm going to do the operation, but you have to prepare that your vision after the operation maybe won't be optimal, or maybe before the operation you will refer it to your retina colleague for treatment before the operation. Okay, so we all want our cataract surgery patient to be 20/20 post-op, right? But if you don't see the retina, if you don't analyze any part of the eye besides the lens, you might get in trouble. So this one is, as I mentioned before, for education. This is for enhancing patients' compliance, and also studies, maybe in large hospitals, they want to conduct some studies. OCT is really, really important to find a new biomarkers for, let's say, disease progression or disease management. And why do you need to invest in OCT? Because if you want to have a comprehensive eye examination, the OCT can give you, it can be used not only for retina or posterior surgeon or retina specialist. You have an anterior OCT for your anterior colleague. The retina doctors can use it, of course. Glaucoma doctors, neuro-ophthalmology. So if you have OCT, you will have less referral. So the patient that you usually refer to your colleague or other clinic, you can actually keep in your clinic yourself, and also to expand the capacity of care. Value for money, of course, if you have one device for all, because this is TopCon. So, for example, Maestro or Triton, it's an OCT device that has fundus photo, infrared, fundus autofluorescence. You can actually do angiogram, fluorescent angiography. So you don't need several machines to do all of that. So it's value for money. And this one, especially in Indonesia, our government insurance is called BPJS. So most doctors will ask, if I buy an OCT, will the reimbursement of BPJS, will I have a reimbursement from the government insurance? Yes. The answer is yes, and it's quite good. So you can, this is a faster return of investment, because you don't have not only paying patient come to you, but the reimbursement is good. But also you have to, the doctor have to account for the clinic's value, patient demographic, and local competition with other clinics. Okay, in summary, the OCT brought significant contributions in the field of diagnosis and monitoring a variety of retinal diseases. It serves as an integral part of not only retina practice, but ophthalmology practice as a whole. It helps disease identification and prognostication. It serves as a treatment guidelines. However, the limitation is still limited by ocular mediopacities, or at least before MM pupil diameter to acquire adequate results. Thank you. If you have any questions